Hello, Las Vegas. Welcome to Fertility Thursdays with NFI. I am Dr. Cindy Duke, Medical Director and Physician here at the Nevada Fertility Institute. I am really excited today to talk about IVF. And so I hope today that we can cover some of the history of IVF, why we do IVF, and who might be ideal candidates for IVF. First, to begin with, IVF is actually an acronym. So it's an abbreviation meaning in vitro fertilization. So I for in, V for vitro, and F for fertilization. So in vitro fertilization is a process by which we take eggs from a woman, sperm from a man, and we put egg and sperm together in the laboratory. Historically, the term used was in a test tube, but it actually does not occur in a test tube. Speaking most clearly and most simply put, it is the process whereby egg and sperm are brought together outside of the human body. So that's what IVF is. IVF encompasses a number of steps and a number of different processes within it, and so that's important to know. One of the first questions, or at least one of the questions I find fascinating, is when did this all start? And I know certainly for some of our patients, they're always really intrigued by the idea that we can do so much in the laboratory to aid or assist human reproduction. And to give you some history and some insights into this, IVF, the first baby born of IVF was born in 1978. That baby was born in the United Kingdom, a girl, Louise Edwards, and it was a pretty big deal at the time. It made all the major magazines, the major articles, and it was thought to be groundbreaking, which it was. Certainly, IVF, the process thereby, is one way to help overcome infertility for a lot of patients who are otherwise unable to conceive. And so it's now very common. For example, in the United States, there were well over 250,000 IVF cycles performed in the year 2015. So just 2 years ago, there were that many cycles performed in the United States. And so it's important for us to understand what IVF is and what it means. So within the world of IVF, the very traditional form of in vitro fertilization, like I mentioned, is getting eggs from a woman, often after giving her high-dose medications for somewhere between 10 to 12 days. And then a trained physician, such as myself, usually a reproductive endocrine and infertility trained doctor, will then retrieve or harvest those eggs from her ovaries, usually while she's sedated or asleep. And then we obtain sperm, either from her partner or from a donor, and we put sperm and egg together. If you put one egg with a number of sperm, that is what is known as traditional IVF, meaning you put the egg in a dish and you put sperm in there and you look and wait to see which sperm will fuse with that egg, i.e. fertilize the egg to create an embryo. That is traditional IVF, in vitro fertilization. Nowadays, we have more advanced techniques. So for example, in the case of, say, where the sperm aren't functioning as well as they might, or where there's concern that sperm may not be functioning ideally, we perform ICSI, intracytoplasmic sperm injection. ICSI. ICSI was developed in 1992 by Dr. Palermo, and it was groundbreaking because it actually helped to address a particular subset of infertility, which is male factor infertility, meaning infertility that's related to something due to sperm or due to something from the male partner in the relationship, with sperm being unable to either get into the egg to fertilize it or some other reason, ICSI helps to overcome that, because the embryologist, the specialized person in the laboratory, is actually able to inject the sperm directly into the egg, thereby bypassing the usual traditional IVF step of waiting to see which sperm will spontaneously fertilize the egg. And so those are some of the general things to know about IVF. But who should get IVF? Well, IVF is available to everyone, but certainly the patients who are definitely recommended for IVF would be patients for whom their fallopian tubes are blocked. So if your fallopian tubes are blocked, then there's no natural way for sperm and egg to get together, because as you may recall from one of our prior episodes, in order for fertilization to occur, sperm and egg meet in the fallopian tubes. And so in the context of having blocked fallopian tubes, either from a history of a tubal ligation or scarring as it relates to diseases such as endometriosis or pelvic inflammatory disease, or infections such as chlamydial infections that led to scarring of the tubes, the way to conceive, or if you've had, say, an ectopic pregnancy or ectopic pregnancies that resulted in your fallopian tubes being removed to treat the ectopic pregnancy, then IVF, in vitro fertilization, becomes necessary. And so that's one group of people for whom IVF is necessary. Someone with tubal factor, meaning blocked fallopian tubes. Other patients for whom IVF become necessary are patients with male factor. Not only IVF, but they require that specialized procedure within the realm of IVF known as ICSI, which is intracytoplasmic sperm injection. And so that would be in men for whom either they're not able to ejaculate sperm on their own to have enough that can make it up to fertilize the egg, or if they've had a vasectomy, or if they have what looks like immature sperm production or sperm that don't move very well, i.e. they're alive but they're not moving well. All those things would be reasons for doing IVF with ICSI. Other reasons have to do with what we know about age and the age-related decline in terms of a woman's age-related decline in fertility due to her ovarian aging. Again, this harkens back to something we've talked about before, but as women, we're born with all of our eggs, and certainly as we age, our egg number decreases, and with that decrease comes also the decreased reproductive potential or competence of the eggs that are there, particularly so. Many times the eggs can be fertilized, they may develop embryos, but the embryos are genetically abnormal. If that's the case, then we actually need to do a few more things to be able to test the embryos. And so if you're someone, for example, who would like to have genetic screening performed on their embryos, whether it be to check the chromosome number, whether it be to rule out a specific disease that perhaps is passed on within the family and you'd like to prevent that from happening, if you require any form of pre-implantation genetic diagnosis or screening or testing, then IVF becomes necessary. Because again, we would have to create the embryos outside of the body in order to test them before getting you pregnant. In terms of other people, well, it's recommended after a number of trials have been performed that women older than age 40 years old should consider IVF as their first line option for pregnancy. In part, again, it has to do with what we know about diminished ovarian reserve, the decreased chance of pregnancy at that age and later, as well as just the need to improve the odds for pregnancy. And particularly if you're a patient who's 40 years or 38 to 40, wanting to start a family and planning a fairly large family, 2 or more children, then IVF might make more sense, given that you can actually bank your embryos, stop the clock in terms of ovarian aging and the age of the eggs that are being used to start a pregnancy. So those are some of the general reasons why people will need IVF. There are a host of other sub-reasons that people will choose to do IVF for, but those are some of the basic ones. Other reasons would be if you've done, our recommendations are if you've done 3 cycles of ovulation induction with or without insemination, and if you have not conceived, then it'll make a good logical transition point at that regard to consider moving on to IVF, moving on to in vitro fertilization. And so those are all reasons why one might want to consider IVF. 1 second here, I'm just going to pull up our page so that I can see if any questions come in while we're doing this. Along the way, patients ask questions like, well, I'm interested in doing IVF, but I hear it's really expensive. And cost is definitely a major concern for many people when they're considering whether or not to pursue IVF. What I would say is, yes, it costs more than spontaneous conception, but you have to weigh the pros and the cons. And certainly a lot of the pros far outweigh the cons when it comes to IVF and pregnancy and what your goals are related to pregnancy. And so those are things that I ask everyone to keep in mind. In addition, cost varies on your location, what you may need, and certainly here at Nevada Fertility Institute, we're very mindful of cost and have come up with a number of programs aimed at making IVF affordable. In addition to discount programs aimed at helping veterans conceive, etc. So the first thing I would say to anyone is if you're thinking maybe you need IVF, you should just come on in for a consultation, either with our clinic, Nevada Fertility Institute, or consider going to see a reproductive endocrine or infertility specialist in your part of the country or wherever you are in the world. Okay, let's start looking through some questions to see what we have here. So one question asks, what is mini IVF? Mini IVF is sort of the new hot discussion out there. What does it mean? Mini IVF is shortened, and so a lot of things are shortened in our world. You know, like IVF is really in vitro fertilization. ICSI is intracytoplasmic sperm injection. Mini IVF can mean one of 2 things. For the most part, it means minimal stimulation in vitro fertilization. So many people, when they hear mini IVF, they tend to think it means IVF on a small scale or IVF but not as many things involved. That's not true. The basic tenets of IVF hold true even when we're talking mini IVF. So minimal stimulation IVF just has to do with how the medications are dosed, what doses are used, and how many eggs are expected. So in minimal stimulation IVF, you use lower doses of medications to stimulate the ovaries to get eggs. And in turn, you can expect to get way less eggs from the ovary than you would in traditional IVF. So that's the first thing. But who might be a candidate for mini IVF? Well, certainly mini IVF is now considered a better option for many patients with what we call diminished ovarian reserve, meaning the number of eggs you have is so low that the ovaries, whether or not you give a whole lot of medicine versus a low dose of medication, will only give you so many eggs. It's just limited because the number of eggs left or remaining in the ovary is lower. And so what we've seen is that for patients in that context, minimal stimulation doesn't make a big difference in terms of egg yield. And for some patients, actually, it actually would lead to a yield of eggs from the ovary, as opposed to knowing they don't have many eggs there and giving them a high dose stimulation, just throwing high doses of injectable medications at them, doesn't necessarily lead to the ovary actually waking up and producing the few eggs that are there. So that's in short, mini IVF. It really means minimal stimulation in vitro fertilization. The process of taking out the eggs is no different from traditional IVF. The process of fertilizing the eggs is no different from traditional IVF. The time it takes to know if you have embryos is no different from traditional IVF. If you need genetic testing, the genetic testing performed with a mini IVF cycle is no different from a traditional IVF cycle. Some patients are recommended for mini IVF in part because they need multiple cycles to get enough eggs to actually be able to create embryos and move forward with genetic testing, etc. And so mini IVF protocols, i.e. minimal stimulation IVF protocols, are helpful because it allows the patient to keep costs at a more realistic or more affordable range per cycle. Although when you add up all the cycles, it still adds up to be equal to a traditional IVF cycle or more sometimes. But it allows patients to be able to do those multiple cycles to stack up as many eggs as they would need, given that their ovaries won't give them a whole lot in any one cycle. So again, mini IVF is especially worth considering in patients with diminished ovarian reserve. These tend to be patients who are older, tend to be patients for whom it's that versus considering doing donor egg, meaning getting an egg from a younger woman, or a patient for whom they're more interested in what's called natural cycle IVF. Again, the general process doesn't change. The only thing that's different here is what type of medications are used and how many eggs are you expecting at the end of the IVF stimulation cycle. Okay, let's look for other questions here. So another question, the medications used for in vitro fertilization, how is that determined? Same or varies? The medications tend to fall into general classes, but it varies. It varies by the physician. It varies by your physician's evaluation of you, the patient. So a lot of the medication should be, the dosing, i.e., should be based on the patient. It should be based on what we know to be the patient's ovarian reserve, i.e., how many eggs you potentially have. It should be based on if you've had IVF before or if you've done any other type of reproductive assistive procedures. It will be based on that if we know what your experience or response was to those. It's partially based on the patient's age, but mostly it's 3 or 4 general classes of medications. So if you're doing a traditional IVF cycle, traditional IVF involves injectable medications for the most part. And these are medications that fall into certain classes. They're known as gonadotropins. And basically they're medications that are either recombinant, meaning they're synthesized in the laboratory, but they're synthesized to be identical to messages made by your brain, by your pituitary gland, or they're actually derived from the urine of, for the case of one medication, was derived from the urine of nuns in Italy. And so it's used to stimulate the ovaries. And so these are gonadotropins. Again, they're mimicking what the brain usually does with the ovary, but in much higher doses. That's what the injectable medicines are. Is they're basically mimicking what the brain's messaging to the ovaries are, but in much higher doses, meant to wake up the ovary, but not just wake up the ovary, but to rescue as many eggs out of the ovary in any one cycle as is possible, compared to usually in your normal menstrual cycle. Your body starts off by selecting a group of eggs, and it starts like a marathon with those eggs. And over the course of 2 to 3 months, it selects one egg to win the race. And that's the egg you would usually ovulate. In the process of IVF, we're actually trying to rescue all the other runners in that race that were being told to just fall off. You're not in the race anymore. In IVF, we're trying to rescue the other runners in addition to the 1 or 2 that would have been ovulated. So that's the key to know about IVF. Next question. Is IVF the same process used to get eggs when you donate them to another couple? Yeah, so IVF, in vitro fertilization, is the process where you take eggs and put them with sperm, but we use the same stimulation protocol, meaning the medications to stimulate the eggs in an ovary of a woman who maybe wants to be an egg donor, or if maybe this is a woman who is diagnosed with cancer or some other disease process that renders her potentially infertile in the future, or she now needs some treatment that can damage her ovaries or her eggs, we can actually use medications to do the same stimulation to get eggs out of her ovaries. But instead of going one step further and fertilizing it, we would freeze the eggs. So we try to get mature eggs out of the ovaries. And if she's someone who's donating her eggs to a couple, and there are young women who do that, it's called egg donation. We take the eggs, but we do the same process in terms of medication, the same process for harvesting or retrieving the eggs from her ovaries. Next question. Okay, so we have one other question, which is how long does it take to start before starting IVF? Well, it varies. Typically, let's say you come into our office, excuse me, and you're interested in doing in vitro fertilization. There are certain steps that have to be taken first to make sure that you're healthy, make sure we know how many potential eggs you may have, make sure your general health is well, especially if you're a woman who's doing IVF with the intent to carry that pregnancy. We not only have to make sure that we do all the investigations needed to figure out how to dose your medications for IVF, but we want to make sure the uterus is ready for the transfer of an embryo, or as I say, we want to make sure the house is good for a tenant, right? So we do some investigations to look at the uterus, to look in the cavity, just to make sure the house is good for a tenant. If you're a woman older than 40, for example, we want to make sure that your mammograms are up to date, make sure there's nothing there that we're going to miss. If you're a woman, African American woman or African heritage over 45, we want to make sure you've had your colonoscopy. If you're a woman over 50, we definitely want to make sure you've had your colonoscopy and anything else that's age related and appropriate, recommended for your age before we get you pregnant, because certainly it would be very unfortunate for a patient to have to make such a difficult decision if they were to find out they were now like breast cancer positive or colon cancer positive while pregnant. It requires some really tough decisions. So we try to help the patient not have to make such tough choices by doing our due diligence ahead of time and testing and screening for these things first before we get you pregnant. Next question. If you have a cancer diagnosis, is IVF what is used to save the eggs? Yes. So if you have a cancer diagnosis, it all depends on your age. It all depends on whether or not you have a partner or not. So in women who have a partner, let's say she's married, she's diagnosed with cancer, and they're about to embark on treatment using specific types of chemotherapeutic drugs or radiation therapy to say her pelvis or her whole body that we know will affect eggs, or in the case of a guy, his sperm, we recommend considering fertility preservation if there's time. And so we work closely with your cancer doctor, and if you're married or if you have a long-term partner and you've both decided already that you want to have children together, we will do IVF in the sense that we get eggs from the female patient with cancer and we get sperm from her partner. We create embryos, which is fertilized eggs, grow them out for 5 days, and then we freeze them. And those can stay frozen in perpetuity, meaning they can stay frozen for as long as needed until this patient undergoes her cancer therapy, is declared free of cancer. For example, in the case of most women with breast cancer, which is one of the more obvious examples that we use, a woman's diagnosed with breast cancer, she's recommended for certain chemotherapy, which is known to affect her ovaries and can affect her eggs, i.e. destroy the eggs. she's recommended to consider getting her eggs frozen if she is interested in preserving future fertility. A patient like that, once she's undergone her chemotherapy, she can go on usually to get pregnant with her frozen embryos, but it's usually recommended that she wait about 5 years, meaning she goes 5 years cancer-free before she gets pregnant. Some patients would freeze embryos but may then decide, you know what, I'll have someone carry the pregnancy for me. So that's sort of what we call surrogacy, gestational surrogacy, or more medically termed gestational carrier. So those are certainly options, but yes, in terms of basics, IVF is what we use to get eggs, or elective or medical egg freezing for a patient. We can also freeze eggs, of course, for patients who simply want to delay fertility or maybe haven't met the right person, or a woman who recognizes she's getting older. I never like using that word because I'm in that same category, but isn't quite yet ready to start her family, but she doesn't want to lose the best years of her eggs. She can freeze her eggs. That is called elective or social egg freezing. Okay, let's see if we have any other questions here. Do you do egg donation at your clinic? We are part of a network that allows egg donation, yes. So if you are a patient, perhaps you've already found out that you don't really have many or any eggs remaining in your ovaries, and you've now been recommended for donor egg. Yes, we do donor egg. We have a third-party program here. We have a nurse whose primary focus is working with patients who need assistance, either in locating donor egg, locating a uterus, i.e. a gestational carrier or surrogate, or donor sperm. So if you're a single woman and you either already found out you don't have many eggs left, so you want to get pregnant, but you'd like to use donor egg and donor sperm, we're here to help. If you're a single woman who still has eggs, but is in need of sperm, we can help assist in locating sperm. We help direct you to the sperm banks and help counsel and guide you as you make your selection. So the short answer is yes. We have egg donation program here at our clinic. We are able to help you either find eggs from egg banks, i.e. these are FDA regulated, so Food and Drug Administration regulated companies in the United States whom have already paid younger women who were willing to volunteer and donate their eggs. They did the stimulation, collected their eggs, and now have them frozen, and you are now able to select from those, or you find a donor and then you go through the process of obtaining eggs from that donor in real time. Okay, let's see if we have any other questions. One question is, what are some of the complications or dangers of IVF? IVF is honestly very safe, but like any medical procedure, there are some complications if it's not carefully done. So in terms of in vitro fertilization, the act of stimulating the ovaries, as we talked about, we're giving you higher doses, much higher doses, or what we call supra-physiologic doses of the hormones that usually are produced by your pituitary to message the ovary. And the act of doing so can lead to many more eggs being rescued from that cycle, and thus we get the eggs for fertilization. The act of doing that in someone who maybe has a lot of eggs is that you run the risk of causing what's called ovarian hyperstimulation syndrome, which can lead to accumulation of fluid in the abdomen, in the lungs of a patient. Some patients are at increased risk for blood clots as a result of that. Some patients end up having to be in the hospital or in the intensive care unit. So that's one of the potential complications of IVF. It's not very rare, and that's because it's so much more understood here in the US, and there are now ways to mitigate or abrogate those symptoms so that someone may have mild symptoms of OHSS but not develop the severe cases that we see that can lead you and land you in the hospital. Other complications related to IVF really are related to how many embryos you transfer. And I can tell you, every patient, practically every patient who comes in to see me, and is interested in IVF is also interested in getting pregnant with twins. Everybody wants it. And they all want one boy, one girl, because they want to be one and done. And so we actually sit down and we talk about that, because we actually do not recommend, and when I say we, I mean reproductive endocrinology and infertility specialists as a whole, not just in the United States, but globally. We do not recommend transferring more than one embryo at a time, especially if you've already genetically tested the embryos and know that they're genetically normal. We recommend one at a time, except in certain unique cases. And so case by case, sometimes your doctor will recommend more than one embryo being transferred, but as a whole and as a position statement, we recommend considering one at a time. And that's because we know what the risks are related to pregnancy with more than one fetus, right? And so I know it's cool, it's really sexy to think of being able to have your 2 children all at once. But if we transfer 2 or more embryos, particularly embryos that have been tested and are genetically normal, chance of twins is very high. It could be as high as 44% chance of twins transferring 2 genetically normal embryos. And keep in mind, for every embryo that implants, it can split. It can turn into 2 or 3 babies. So you have the potential of transferring 2 embryos, but we could easily be talking 4 fetuses once they're finally implanted, and if they go on to split into identical fetuses. And so with that, we recommend one at a time so that we can decrease the risks related to having that many babies in there. And those risks are both for mom who's carrying this pregnancy with this many babies, and for the babies themselves. So the more babies you carry in your uterus at any one time, the higher the chance of those babies being born preterm, the higher the chance of them needing to be in the neonatal intensive care unit, having a lot of treatments, including having tubes put down their throats to help them breathe, high dose oxygen, risk of infection, all those things. And then there are risks related to mom. So the more babies she's carrying, i.e. the more placentas growing in her uterus, she's at higher chance of developing diabetes during pregnancy, of developing preeclampsia or high blood pressure related diseases of pregnancy. She's at higher risk of bleeding out at delivery or hemorrhaging. She's at higher risk of needing C-section and other forms of surgical delivery. In addition to all that, she's at higher risk of needing to be on bed rest, which then increases her chance for things like blood clots, etc. So very risky, and the party line here is we recommend the fewer embryos, the better, with the goal ideally being elective single embryo transfer, or ESET, as we call it, ESET. Okay, let's see if we have any other questions here. Okay, so another question, so we asked about the complications of IVF. Another asked about the diagnosis. So we've made our way through those. In terms of other questions coming in, one message is asking, is there an age limit for IVF? There are no set age limits, and certainly IVF, like I said, is sort of a gateway into a larger conversation and larger technologies that are available. So while we may not be able to get someone pregnant with their own eggs, we may be able to use a donor egg. And so in that case, and a woman can be older and still conceive. And so there's no specified age limit per se. Here at Nevada Fertility Institute, we sort of capped it at age 58, but that still means the patient has to undergo a very rigorous health screen. She has to be physically able to carry her pregnancy versus if she were using a carrier. That's a different conversation. So the short answer is no specified age limit per se. It's a case-by-case basis, and it all depends on what's going on with the patient, the family, and what their goals are. Okay, another question here asks, what if I want to do genetic testing, but I don't want to do IVF? That's a question that comes up from time to time. And the short answer is, if you're someone who wants to have their embryos tested before pregnancy, the only way to do that at this point is with in vitro fertilization or assistive reproductive technologies, i.e. creating embryos in the laboratory, testing them, and then transferring the normal ones. And by normal, I mean genetically normal, or what we use the term euploid. I actually don't like using the word normal or abnormal, but for layman's speak, we'll say normal or abnormal today. Otherwise, the genetic testing, I mean, you can always test while you're pregnant to find out if you're pregnant with, say, a fetus that is Down syndrome, etc. That is a possibility, and the technology exists and has existed for a long time. It can be as simple as a blood test performed around the 10th week of pregnancy, whereby you're able to get a sense of whether you're pregnant with a boy or girl, and certain genetic abnormalities are able to be tested for. Or you can have a sampling of the placenta done around 12 to 14 weeks of pregnancy. That's known as chorionic villus sampling, CVS. A little bit of the placenta is taken out while you're pregnant. Or you can have what's known as an amniocentesis, which is a doctor, specialized OBGYN, a maternal fetal medicine specialist, collects some of the fluid that's growing within the uterine cavity with the baby around 18 to 20 weeks of pregnancy, and they send that off for genetic testing to see what's going on with your fetus. The difference for all those tests that happen during pregnancy versus what we can do in pre-implantation genetic testing is, with one, you're pregnant, and so there are risks related to pregnancy when you're doing those tests, and of course it also means probably having to make a decision about what to do about the pregnancy if it were abnormal, versus knowing this stuff ahead of time and thus making the decisions pre-pregnancy. Okay guys, so let's see if we can test through. And then, okay, so another question here asks, can you test for cystic fibrosis? So cystic fibrosis is a genetic disease. It's a disease wherein a child can be born with cystic fibrosis if they inherited one mutated copy of the cystic fibrosis gene from their mother, or from the egg, and one mutated copy of the cystic fibrosis gene from the sperm. Together, they will cause this disease in the neonate that is pretty severe. So cystic fibrosis is a lung disease. It leads to children being in and out of hospital a lot. As from birth onward, they tend to require lung transplants later on in their teen lives to make it into adulthood, although some do make it into adulthood. It's a genetically inherited disease. It's one that's carried, meaning people can be what we call silent carriers. So if you carry one mutated copy and one normal copy, you're fine. But you now have the chance of passing that on to an embryo, especially if your partner or the sperm source also has a mutation. There's a 25% chance if sperm has one mutation, egg has another mutation, that when combined, they can cause cystic fibrosis disease in a child. So the question asks, can we screen for it with IVF? And the answer is yes. Let's say we have a male and a female who are both carriers for cystic fibrosis, i.e. silent carriers. How would we have found out though if it's silent? Well, actually we perform screening, and we offer genetic screening. Screening for cystic fibrosis is actually recommended by the American College of OBGYN and by the CDC for all patients considering pregnancy or who are pregnant. It's a recommendation. And so if we found out that both parents-to-be or the intended parents are carriers, we would first offer them counseling to talk about what that means and the implications and the possibilities of what can happen with their children. The same applies to sickle cell, by the way. Someone can be a carrier for sickle cell, both parents, and now their child is at risk of being born with sickle cell disease. And so we're able to actually screen embryos for that, and we can test and tell you if the embryo is carrying the gene or if the embryo will actually be born affected with the disease. And certainly that would be one reason and indication for doing IVF with pre-implantation genetic testing, specifically type of test known as PGD, pre-implantation genetic diagnosis. Here at Nevada Fertility Institute, we recommend that every patient who is planning IVF consider carrier screening, given that we have that option to test and are able to determine pre-pregnancy which embryos are at risk and which ones are not. Okay, other questions here. Okay, this question says, I'm a diabetic. Can I get pregnant with IVF? Excuse me. Short answer is yes. Here at Nevada Fertility Institute, whether you're planning IVF or any form of pregnancy, if you are a diabetic, we take that seriously. We certainly make sure we screen all patients to know if they're at risk for diabetes or are diabetic. And if you are diabetic and planning pregnancy, we work very closely with your doctor. If you don't already have one, we send you to see specialists for your diabetes, and we work closely with them to get your sugars under control. And this is because diabetes, high blood sugar, is actually known to be what we call a teratogen, meaning it can cause abnormalities in your fetus. It increases your chance of first trimester miscarriage. And so if you're a diabetic, planning to get pregnant, doing IVF, we especially want that after you've gone through this whole process, that your first trimester goes as well as it can. And so we aim for better control and good control of your sugars pre-pregnancy, so that during that pregnancy, especially the first trimester, when the heart is forming, if the sugars are high, then the heart doesn't form well and you can have a septal defect, meaning a big hole in the heart. If you're a diabetic and if sugars aren't well controlled in the first trimester, the heart may not form well. For others, the brain may not form well. For others, the spinal cord may not form well. And for some, you actually have a miscarriage in that first trimester if your sugars are not well controlled. And so yes, if you're a diabetic, you can do IVF. It requires a little bit of legwork at first, because I like to make sure you're well covered, well managed, that your sugars are under control before we get you pregnant, but we can do that in tandem. We do them together. Same thing for patients with high blood pressure, etc. It doesn't mean no, you cannot get pregnant. It means we start taking steps before pregnancy. Yes. Okay, let's see if there are any other questions here. If not, we're going to start wrapping up here. And so, are there any supplements you recommend to help for IVF or pre-IVF? Absolutely. You know, supplements in general, I tell every woman who's thinking she's planning pregnancy or might get pregnant, meaning if you know you're having sex and it's unprotected sex or condom could break or whatever, you should be taking a prenatal vitamin. If you don't want to take a prenatal vitamin, you should at least be taking folic acid. So folic acid is a vitamin. It's part of the B complex of vitamins. It's integral for how the brain and spinal cord forms. Interesting and critical thing that everyone should know is the brain and spinal cord start forming somewhere around 21 days of pregnancy. That's 3 weeks. Most women don't even know they're pregnant until at least 6 weeks in. And so if you're not on folic acid, and if it turns out you have a folic acid deficiency, by the time you find out you're pregnant, the potential damage from the deficiency has already happened. And what are the potential damages? Well, folic acid deficiency is linked to spina bifida. So you have incomplete fusion of the spinal cord and the vertebrae over the spinal cord. You can have the brain not forming at all, and so you have a baby that's growing but it has no brain, i.e. it's anencephalic, so they don't survive once they're delivered. You can have, there's now some data that suggests folic acid deficiency is related to autism, perhaps. It's also related to different forms of birth defects as it relates to the face, or craniopharyngeal defects. And so supplements for sure, folic acid. If you're an older woman, age 35 or older, I recommend you get CoQ10 and DHEA. There are specific doses that are recommended. If you come in to see us, we'll talk about that and how you can get that dosing. Those would be the general ones. There are some more specific things that we recommend depending on what the patient's physical status is, her health status, and her nutritional status, but it all depends. Okay, looking through, I think we've worked our way through most of our questions. Thank you so much for joining. Again, we continue to appreciate the direct messages, the emails, the text messages, and I look forward to us talking some more about other things as they relate to fertility. Send us in your ideas. Send us in your questions. We are very responsive to those questions, and also very much willing to discuss them during one of our future Facebook Lives. Until then, just to summarize, today we talked about IVF. What is it? How long has it been around? Ever since 1978, it's been around. How often is it done? It's done regularly in the United States. In 2015, there were well over 250,000 IVF cycles performed in the United States, and at least 1% of babies born in the United States are born as a result of IVF or other assisted reproductive technologies. Who does IVF? Usually it's a fertility clinic, and a reproductive endocrine and infertility specialist performs IVF. IVF is nowadays a sort of broad umbrella term for a number of other things that can be done to help someone get pregnant, but the basic gist is that IVF involves taking egg, taking sperm, putting them together outside of the body. Some patients absolutely have to have IVF in order to get pregnant. For others, IVF becomes the next step in their treatment when other less invasive steps have failed. Okay guys, thank you so much for joining. Looking forward to seeing you again in a couple weeks. Just making sure one more time that there's nothing here that we miss. And until then, take care. See you. Bye-bye.